Okay. Our next speaker is Dr. Adnan Khattak from the Fiona Stanley Hospital. And the next study is he will present the results from a phase 1 dose escalation trial with the soluble LAG3 protein IMP321 together with pembrolizumab in unresectable or metastatic melanoma.
Thank you, David. First of all, I'd like to thank the members of the organizing committee for giving me the opportunity to present our research here all the way from Australia. I take it this is the only study from outside the US being presented in this session. On behalf of my co-investigator, it is my pleasure to share with you the results of the Technimal phase 1 study, which was looking at the combination of soluble LAG3 protein IMP321 with the new name of eftilagimod alpha, or more commonly known as FT, together with pembrolizumab in unresectable or metastatic melanoma. These are my disclosures. So I'll start off by explaining the mechanism of action of IMP321 or FT and how it's different compared to the traditional anti-LAG3 compounds available. So the talk after my talk is MP4280, which is a Merck compound targeting LAG3 molecule, which has got an antagonistic effect. So on the right side, how does the cursor work? Oh, yeah. Yeah, as you can see on the right side of the slide, so we got LAG3. So LAG3 is a transmembrane protein which is expressed on the surface of activated T cell. It is a marker of T cell exhaustion. And the monoclonal antibodies currently targeting this LAG3 molecule are being evaluated in phase 1, 2, and phase 3 studies. And the traditional way of explaining to the patient is it's an immune checkpoint inhibitor, and it acts by taking the brakes of the immune system. In contrast, on the left side, you can see the soluble LAG3 or FT. It is a fusion protein made of the Fc portion of the human IgG molecule in combination with the extracellular domain of LAG3. And then this has got an agonistic effect on MSC2 expressed on the surface of antigen-presenting cells. So this is its primary effect. And then its secondary stimulation leads to stimulation of multiple immune cell subsets, including T cell, natural killer cell, and monocytes. The other difference is that the anti-LAG3 antagonist monoclonal antibodies, they act on the pre-existing pool of activated T cells, whereas FT is through its secondary effect by a stimulating antigen-presenting cell, can also lead to extra CD8 T cell stimulation and production. In terms of pharmacodynamics, IMP321 administration leads primarily to sustained increase of circulating antigen-presenting cells like monocytes and dendritic cell. As you can see on the left side, there is an increase in the monocyte count, so pre-dose at 3 months and 6 months, and also the CD16, which is a marker of monocyte activation, is also increased pre- and post-dose at a baseline as well as 6-month mark. The secondary effect, there is a secondary effect on there's an absolute sustained increase in the number of CD8 affected T cells and also interferon gamma. In terms of pharmacokinetics, so this is 1 milligram, 6 milligram, and 30 milligram, the 3 doses that were tested as part of this study. There's a dose proportional increase in the pharmacokinetic parameters like AUC and also Cmax. But this relationship is not linear, and there's a variability between patients receiving the same dose. And as you can see, this is nanogram per ml dosage concentration in the blood, which is required to produce sustained APC activation. Now, what is the rationale for combining pembrolizumab with a soluble LAG3 FT? We know that a robust innate immune system is required for survival and response to pembrolizumab. And there's some very recent data published in Nature Medicine recently, which shows that the low monocyte count at baseline is associated with a poor efficacy of anti-PD-1 therapy in melanoma. And as I discussed in the previous slide, FT leads to APC activation, and there's an increase in monocyte count. So this is the design of the Technimal study. So it had 2 parts, Part A and Part B. So I'll be presenting the result of Part A only today. So this study was conducted in Australia in about 6 sites. So patients with unresectable or metastatic melanoma were treated with 3 cycles of pembrolizumab. Now, those patients were eligible for this study who had either an asymptomatic disease progression or had stable disease or had a partial response. After 3 cycles, so this was according to immune-related response criteria. It is not IR resist or I resist. So the patient was screened at the time of cycle 4, and if they were deemed eligible, FT treatment was started once every 2 weeks for a total period of 6 months subcutaneously, starting from cycle 5 of pembrolizumab. So 18 patients were enrolled, 6 patients in each cohort, 1 milligram, 6 milligram, and 30 milligram. And pembrolizumab was given on a dose of 2 milligram per kilogram once every 3 weeks intravenously as per standard dose. Imaging was carried out once every 3 months. In terms of safety summary, so the table on the left side is summarizing the grade 3-4 treatment-related adverse events. So there were no grade 4 adverse events noted that were attributed to either FT or pembrolizumab. There were 3 adverse events, grade 3 adverse events related to pembrolizumab, which is the maculopapular rash, colitis, and abnormal LFTs. The only grade 3 adverse event attributed to FT treatment was abnormal renal dysfunction. There were no dose-limiting toxicities observed in any dose level. There were 6 serious adverse events, none related to study treatment. On the right side in the table, you can see all the treatment emergent adverse events that were seen in at least 10% of the patient, and these included arthralgia, diarrhea, fatigue, hyperglycemia, and nausea. There were no new safety signals noticed. I would also like to point out that the hyperglycemia grade 3 and 4 was not attributed to either of the studied treatments. One patient died, it's actually my patient, unfortunately died due to disease progression in the brain with intracranial hemorrhage, which was thought not to be related to the treatment. In terms of baseline demographics, you can see the table on the left side. So median age was 67 years. Majority of the patients were male. As highlighted in the, this was a really bad prognostic group. So it didn't take patients up front. It took patients who had suboptimal response after 3 cycles of pembrolizumab. And also, 40% of these patients had an elevated LDH, and about 80% of the patients had M1C disease, including one patient with brain metastasis, which was stable at the time of participation. 5 patients had prior treatment, 2 with ipilimumab, and 3 with combination beta MEK inhibitor. So about 2/3 of the patient had immune-related progressive disease or stable disease at the time of enrollment in the trial. On the right side, the efficacy data. So there was 1 complete responder. There were 5 partial responders, including 1 patient who had complete disappearance of all target lesions, but there was persistent non-target disease left. So that's why it's classified under the umbrella of partial responders. About 1/3 of the patients were those with stable disease, and 1/3 patient had progressive disease. The best overall objective response rate was 33%, with a 56% tumor shrinkage. And the disease control rate, 66%. Now, this was not a pre-specified target that or endpoint that we're evaluating, but if the response was calculated from the time when the patient started treatment till the first response assessment or the best response noticed on the trial, so the objective response rate comes to 61%. On the left side, we got the waterfall plot. As you can see, the blue bar representing the complete responder, and the yellowish green lines representing those who had partial response. And there were 4 patients represented in the gray bar who had stable disease, but you can see that the cutoff of immune response criteria is 50% to be called a responder. Tumor shrinkage was seen in 56% of the patient. In terms of spider plot, so the blue line reflecting the complete responder, and then there were 4 patients who still continue to be in treatment 12 months later. This is one of the cases who was treated as part of this trial, an 84-year-old gentleman with BRAF wild-type tumor who had multiple lung metastases. This is the baseline scan on the left side. So. And then at week 9, so just before the patient got started on the trial, the patient had disease progression. And then there was subsequent decrease in the tumor volume. And at roughly around about a 1-year mark, there was a complete disappearance of the target lesions. So in terms of take-home messages and conclusions, FT in combination with pembrolizumab was well tolerated with no new safety signals observed. The combination showed encouraging clinical activity in patients with suboptimal response to pembrolizumab monotherapy. Tectimil Part B is ongoing in Australia with no dose-limiting toxicities noticed so far, and these results warrant further investigation of exploring this combination in melanoma and other tumor indication. There was a poster presentation today, Tectimil 002, exploring this combination in non-small cell lung cancer and head and neck cancer. And then I would like to thank all the patients and the families for participation in this study, and my co-investigator and the sponsor Immutep for sponsoring this research. Thank you.
We have time for 2 questions. Is there anybody? Okay. Since we're a little behind time, we'll go ahead and proceed. Thank you very much.